started from taking blood from peripheral for collection.
But my dream was to do more than 200 transplants every year. So,
What is the age of first bone marrow transplant in Turkey?
if you do not teach the nurses, your nurse team is weak, you couldn't do good things.
How long you did a residency program in Hutchinson?
Also, if the donor is antibody to hepatic B,
Hocam merhaba.
Merhaba.
Hoş geldiniz. Selamünaleyküm. Özbekistan'a ilk defa değildir. Kaç geldiniz?
doğrudur. Bu üçüncü oluyor zannedersem.
Maşallah. Hocam siz
Güzel memlekette olmaktan çok mutluyuz.
maşallah. Biz de mutluyuz. Özbekistanlı birkaç hastamız sizi çok seviyor.
Evet.
Maşallah. Ben şimdi İngilizce'de konuşalım.
Okay, let's talk English.
Let's talk in English. Okay. Can you please tell me about your education? How it started? To which university you went? After university, why you choose hematology? How you become an oncohematologist?
Okay. So I was graduated 1977 from the Hacettepe University, Ankara. After Hacettepe University education, I did with obligatory administrative duty, and then after I started to do internal medicine. After finishing the internal medicine, I have to decide the subspecialty, hematology, cardiology, oncology, etc. At that time, cardiology was famous, and so I decided,
Even now it's famous, cardiology, yeah?
yeah, but now not. Now not. In Turkey, now not.
Okay.
And I entered the Ankara University cardiology examination. I win, and then they suggested me to be the chief of cardiology laboratory, etc., etc. But I did not like the boss of the cardiology, and I prefer to go to hematology because of this. And then I did hematology. There was one guy from the America doing hematology, and then coming to Turkey, and he wanted me, and then I went to him place, and then I educated hematology with him. There was no other hematologist doing real hematology in the other universities. So he is the only hematologist doing America to hematology, and we started to work together, and then I finished the hematology, and then I planned to do another subspecialty, bone marrow transplantation coming more popular, and our country need the bone marrow transplantation physicians. So I decided to do, after the hematology, bone marrow transplantation education. First, I went to Hadassah Hospital in Jerusalem. There was a famous man. Now he
Hadassah
Hospital in Israel, and he explained the haploidentical stem cell transplantation. At that time, he was not very famous, but I went there, and then I educated there, and after I see the haploidentical transplantation in 1994, but haploidentical transplantation get popular after 2010. He was already doing that time the haploidentical transplantation, and then after Hadassah education, I decided to go to the Fred Hutchinson Cancer Research Center, Seattle.
In America.
Seattle, yeah, in America. The Donald Thomas win Nobel Prize, and he described the bone marrow transplantation. Because of this, he win the Nobel Prize, and he was the chief of Fred Hutchinson Cancer Research Center.
Okay.
I went there, and then I worked as a resident there 1 year, and then I did my real education about the stem cell transplantation.
In Seattle?
There. In Seattle, yeah.
What is the hospital name?
Fred Hutchinson Cancer Research Center. This is interesting. Everybody remembers Seattle, But Fred Hutchinson is a baseball player.
Okay.
He died, and his brother was a surgery specialist, and he asked Donald Thomas, he has the money, how can spend this money? And then Donald Thomas tried to do bone marrow transplantation, but his university, Washington University, did not permit. And then he explained his dream to Fred Hutchinson brother, and then Fred Hutchinson brother told that let's do your dream and then do the building in the Fred Hutchinson building. And then they started there with his team to do stem cell transplantation, and then they explained the stem cell transplantation as a treatment for the leukemia, aplastic anemia, and then bone marrow transplantation developed in the world.
Hocam, your education in Jerusalem and Seattle, it was supported by government?
Yeah, for the USA, not supported government. I did.
Okay.
I did.
You spent your own financial stuff, okay.
And also they paid money for me.
Okay.
And also at the beginning, for 2 months, I spent. After 2 months, they decided that I can work as a resident their clinic.
Okay.
And I started to work as a resident in the Fred Hutchinson. So I worked there as a resident.
How you found Fred Hutchinson? It is like you found yourself, or someone told you that you can go there?
Just I wrote them, and
Okay.
they expected me.
Okay.
Just in America, if you write anywhere, they respond to you.
Okay. This
So
is a very good part of American system.
Yeah, absolutely. Their mission to teach all over the world the bone marrow transplantation.
Okay.
So when I went there was a lot of people coming, Germany, French, Italy, everywhere. So we work together, foreign countries people.
Okay.
And then they teach us there. So also they had primary school, and my children go to their primary school.
How old are you? What was your age when you went to America?
39 years
39 years old.
And I worked as a resident.
Okay. Was you able to take your family to America,
Yeah.
or you was alone there?
Only 3 months, and then after my daughter came with me, and
Okay.
then my family returned back, and then we continued with my daughter all of the years.
Okay.
And
So
then-
you was staying in America with your daughter?
Yeah. And then I turned the university. I established bone marrow transplantation at the Anadolu University, and then the name changed to Osman Gazi. And then we did the stem cell transplantation, autolog and allogeneic. And also we did there the first haploidentic stem cell transplantation in Turkey, first time there.
Okay, I'm sorry to interrupt you, Hocam. How long you did a residency program in Hutchinson Hospital?
Hutchinson,
Yeah,
1 year.
1 year.
Right.
So you stayed in Seattle 1 year.
Yeah.
Then after 1 year, you returned back to Turkey.
Yeah, I returned to my university.
Okay, when you did your residency and education program in MD Anderson?
MD Anderson. So I established the bone marrow transplantation clinic at the
Osman Gazi.
Osman Gazi, Eskişehir. And then after 4 or 5 years later, I decided to learn molecular hematology.
Okay.
So after the bone marrow transplantation, and then I went to Seattle, MD Anderson Cancer Research Center, Molecular Hematology Laboratory and Clinic. And then I learned there, I stayed there 3 months, and I learned molecular hematology, PCR and cell culture. And then I came to Turkey, and then in my department, I established Molecular Hematology Laboratory.
MashaAllah.
And then after...
First in Turkey?
There are some other centers, they try to do that. We started together.
Okay.
And then...
What is the age of first bone marrow transplant in Turkey? The first one.
1976.
1976.
Korkut Özerkan did in the Hacettepe, 1976.
That was
But-
successful or no?
Not much, but he started, so this is a good.
Founder.
Yeah, he's the founder. He's not an organized team, but he started.
He started. Okay.
He started after 4 or 5 years, and then Ankara Medical School started. So every university tried to do something. Also, Gülhane Askeri Medical School tried to do something. And
When do you think the proper build team appeared in Turkey for bone marrow transplant, like boxes, molecular doctor, everyone, like specialized nurses, doctor who has very good knowledge?
this takes time, step by step.
Okay.
And I think after the 2000, the team and organized team, more good teams started to do stem cell transplantation.
Okay. Bone marrow transplant as well?
Stem cell transplant means bone marrow transplantation.
Okay, okay.
And after molecular hematology, I decided to learn GMP stem cell processing laboratory.
Where you go there?
Yeah, and then
where
I
you
go
where
to
you learned this?
Toronto, Canada.
Toronto, oh.
Toronto. And then Francis Margaret Aston, and also I learned their GMP stem cell processing. And then I came to university and I established GMP laboratory for the stem cell processing.
Hocam, sorry to interrupt you. So you first learned hematology with American doctor who was practicing in Turkey.
Yeah,
Yeah.
hematology.
Then
and
you
stem cell transplantation.
Then you went to Seattle and
And
learned.
Hadassah.
First you went to Hadassah,
Hadassah,
Jerusalem.
and
Then you learned about stem cell.
And
Then you went to
Fred
Hutchinson to learn about
stem cell transplantation, bone marrow, and also I learned their flow cytometry laboratory.
Okay,
and
that was
cell
which
culture.
year? Which year? This is
1994.
1994. So after 5 years in 2000, beginning 2000, you went to MD Anderson
MD Anderson.
to learn molecular hematology.
And then GMP stem cell processing laboratory to Toronto.
Which year is this?
I think after 3 or 4 years.
Okay, so it is 2003. You graduated 1977.
I graduated 1977. Yeah.
So you finished 2004.
Yeah, almost. Yeah.
Almost. So 70 years non-stop education.
Yeah, continue.
Continuously education. 17 years after graduation.
Yeah.
After graduation. So to become, as you now, to become a very famous
And
professor.
At the university, we were doing 70 transplant almost every year. But my dream was to do more than 200 transplant every year. So my university did not give me enough bed, enough support. And then I moved to Anadolu Hospital. They built new building for me, stem cell building. And then we started there 2010. And I am still working there.
From 2010, you're working in Anadolu Medical Center affiliated with Johns Hopkins.
Yeah.
Okay, so you built your team by your own.
Yeah.
Molecular doctor, you invited.
Yeah. First, I teach the nurses at the Eskişehir, Osman Gazi, and then we came together to Anadolu.
So you brought your team already who you built in Osman Gazi to Anadolu.
There was a team there.
Okay.
They stayed there. I educated new team in the Osman Gazi, and then I came with the new team to Anadolu. And when I came to Anadolu, there was a really good guy from the MD Anderson Cancer Center chief nurse. He already helped me very much, and he educated all nurses team. So
he came to Anadolu from MD Anderson for education part.
For the education of the nurses and the maintenance, all the nurse responsibilities he is.
Okay. your nurses was speaking English at the time, or
Yeah,
he was doing education with
I already
translator?
choose to speaking nurses English.
Oh,
Because
so
this is the
most
obligatory.
Obligatory.
Yeah.
So in your team to speak in English, it is
Yeah.
obligatory.
Yeah.
Okay. So MD Anderson, chief nurse, came to Anadolu, did education for your nurses.
All the Anadolu hospital nurses education and also our nurses education together.
Okay. How long was that?
He stayed, I think, 5 years in Anadolu.
Wow,
Yeah,
5
yeah,
years.
yeah,
So you worked together
Yeah,
during
yeah,
5
we
years.
worked together.
So
He's
all
really
that
good.
nurses are still been working in Anadolu, or someone left?
Most 50% of them changed.
Changed.
But
Because of what? Age, or they went somewhere else?
everything.
Everything.
So the older one educating the new one.
Okay, older one, educated new one.
Yeah,
Okay,
this-
nice.
yeah. So this is our.
So now,
hospital.
how many bone marrow transplantation you do in 1 year?
We were doing more than 200 transplants every year in the Anadolu until 2 years ago, because we are taking the government patients.
Okay.
Before 2 years ago, we stopped it. We just only doing the special patients, and then because of this stem cell transplantation, we were doing more than 300 transplant every year. Until now, we did more than 3,500 transplant, 150 allogenic, 2,000 autolog transplantation. But now we are doing almost 100 transplant a year now.
Okay. So from when you start working in Anadolu, you did bone marrow transplantation more than 3,500 patients.
Correct.
Okay. I know it's very difficult.
Yeah.
When you hear transplantation, patient thinks it's about surgery. It's not about surgery, right? So from 2000, your first bone marrow transplant was which year?
1995.
1995.
In the Eskişehir. Yeah,
In
we
Eskişehir.
started.
So,
but before already I did Hadassah and Fred Hutchinson.
Okay.
Yes.
So from 1995, bone marrow transplantation, did it change dramatically? It is a big change in the bone marrow transplantation process, or it is still almost the same?
Not still the same. There are big changes. At the beginning, we were collecting the stem cell from the bone marrow. But after 3-4 years, after the 2000, and then stem cell transplant, we are collecting just peripheral blood.
Mm-hmm.
So this is big changing to do peripheral.
Which year it started from taking blood from peripheral for collection?
It started 1995, but came to routine procedure 2000.
2000s.
Yeah, it came to
Approximately.
routine, common all the time. We
All
are
the time,
doing peripheral
okay.
blood. Only for aplastic anemia patients and CML patients, you can do stem cell transplantation from the bone marrow, but it is getting rare. Peripheral blood simple for the patients, simple for the donors, and then this is routine procedure.
Is it painful?
No,
Bone
no,
marrow
no.
transplantation,
It
is
is-
it painful?
It is not painful, just it's a blood transfusion.
Okay.
The donor shouldn't afraid to be donor, because stem cell just we are collecting from the peripheral blood, no adverse effect.
For
And
donor.
for donor, and also it is useful donor. Stem cell mobilization also goes to donor heart or other places. If there is any problem, repair it.
Repairing, okay.
So
So
it
it
is
is
useful also.
useful, beneficial for
For
donor,
donor
also.
for the donor also.
Beneficial for donor also.
So it is just simple blood phlebotomy and blood transfusion.
Okay. Hocam, bone marrow transplantation is beneficial for donor as well. Is there some contraindication for donor to become a donor?
If the donor has a disease like a cancer,
Okay.
they couldn't be donor.
What about this hepatitis B, C?
If the patient does not have any donor, if the only option one donor hepatitis B is positive, if it is inactive, then
It could
be. So,
Okay,
we prefer to do hepatitis B as negative donor, but if we couldn't find only one donor, brother or sister, then if
It's
we
possible.
treat the disease and then we use it as a donor.
Okay. HIV, it's contraindication.
HIV is contraindicated.
HIV is contraindicated. There is some myth, like some patient, some HLI type person can give blood for BMT to treat HIV. Is it true?
To treat the
HIV.
HIV, yeah, this is true. But HIV, you should find the donor CD4 antigen, CD4 negative, but it is rarely available because HIV virus binds to CD4. If the donor, rare donor has not this antigen, and then you
CD4
can use
negative. If I have CD4 negative antigen in my blood, so I can
it
give
could be. But
my blood to
But-
HIV patient to treat him.
But don't think HIV. They shouldn't be HIV. The people shouldn't be HIV.
Of course,
Yes,
but
yeah.
it is widely spread all over the world.
Sometimes, but rarely we are using. Rarely.
Is it in Turkey? There is a bank, blood bank. Yeah,
Donor bank.
Donor
Yeah,
bank.
Yeah.
What is the name?
Turkish donor bank.
Turkish. Turkok.
Turkey.
Do you know, by chance, like just curiosity, is there any patients with CD4 negative in
No.
in Turkok? No,
No.
not possible. Okay. So it is just for some patients who sometimes I'm receiving call. Okay, HIV. Is it possible to find a donor for CD4 negative?
Yeah.
No, not possible.
Yeah,
I say in Turkok it's not available.
It is. But some developments coming, maybe in the future can be. But there are new drugs useful for the treatment of HIV. So
Okay.
it is not a big disease.
Okay, so back to our main topic
Okay.
here. So the most important contraindication to become a donor, it is cancer.
Yeah.
If a donor has a cancer, there was one patient just recently, Nadira. I will not name the family name, but one female patient went to Anadolu. Her brother can give blood, but there was some. You ordered some test,
Okay.
so that test become positive, and you said your brother cannot do the donor for you. Why it was that? What was the point?
Reactive antibody was positive.
What was that?
The usually patients take the blood,
Okay.
and some HLA tissue typing, the tissue is available in the patients, but not available in the blood donor.
Okay.
And then they produce the antibody to some HLA antigens. If you do haploidentical transplantation from the brother, so if the patient has a antibody to the donor brother, then you couldn't do that. So pan-reactive antibody available in this patient, but the donor is not HLA match. If HLA match, it is not important pan-reactive antibody. If haploidentical, if there is a pan-reactive antibody, it can be a problem during the graft failure.
Okay. So now let's talk about to whom bone marrow transplant patients is indicated. So it is leukemia,
Okay.
it is lymphoma,
And myeloma.
sometimes, and the myeloma disease.
Evet. Three disease.
It's three diseases.
Yeah.
Myeloma disease.
Yeah, okay. Let's start myeloma,
Let's
and
start
then lymphoma, and then leukemia.
Okay.
For myeloma patients, if you diagnose the myeloma, if the comorbidity not much, if the patient's performance is okay,
Okay.
we are first we are treating 4 course, and then we are proceeding the stem cell transplantation autolog.
Okay. 4 course, you mean 4 courses of chemotherapy?
4 course chemotherapy.
4 course chemotherapy.
4 course immunochemotherapy.
Immunochemotherapy. Okay.
Usually, this is a well-known treatment in the hematology clinics, but usually they are starting the treatment, they are continuing 6 course, 7 course, 10 course, 11 course. After the disease control, they should proceed to autologous stem cell transplantation. If they wait, then the drugs causes the less stem cell mobilization, get the problem.
Okay.
And especially some drugs, for example, lenalidomide in use treating the myeloma can cause the stem cell mobilization problem.
Okay.
So first, the physicians and the patients, 4 course chemotherapy, if the disease controlled, they should go to the stem cell transplantation.
Autologous.
There are new drugs, but in USA, in Europe, compared to autologous and new drugs, still autologous transplantation more advantageous. So for myeloma, developing countries especially, don't go to the new drugs, receive further the course drug, and go to stem cell transplantation for every myeloma patient's autologous transplantation.
Okay. Hocam, is it stem cell transplantation indicated in acute and chronic myeloma disease?
Myeloma is just multiple myeloma. This is
So
a chronic disease.
There is no
acute chronic.
No,
just
okay.
chronic disease.
Okay, you mentioned about comorbidities in myeloma disease.
Yeah.
What is the usual comorbidities in myeloma
Heart
disease?
problem.
Heart problem.
If ejection fraction more than 45,
Okay.
we can do water transplantation.
Okay.
And
Kidney
lung,
problems?
lung function is okay.
Okay.
And then you should proceed the stem cell transplantation until 80 years. So at 75, 70 years, usually the physician does not send the autologous transplantation more than 60 years old. Usually myeloma is the disease of the patients after after age 60.
Yes.
So we are offering this autologous stem cell transplantation for myeloma patients until 80 years old.
Hocam, I saw in my practice that many patients went to doctor to another division, like they have kidney problems, they have vertebral problems.
This is good question. Kidney problems more frequent in the myeloma.
Okay.
But it is not contraindication for the autologous stem cell transplantation. Sometimes we are doing a lot of patients have renal disease. Some patients' renal problem can be better after the stem cell transplantation. Can you treat with this after the stem cell transplantation kidney more better?
Hocam, in how many percent of myeloma disease kidney problems occur?
Usually 10-20%, not much.
10-20%. So it is increasing KFT, creatinine, and urea. So any other problems like albuminuria happening in renal problems?
Yeah, it can be albuminuria, light chain protein.
So can I say if I see the patient with 60, after 60, female, male, and increasing creatinine and
check the myeloma.
Check the myeloma.
Yeah, if myeloma, give the treatment and then autologous transplantation.
Is it also the same for patients to whom I see the vertebral problems, that osteolytic lesions is happening in the vertebra?
Yeah, it is
in the spine?
Yeah.
It is also common.
Yeah.
So if I see osteolytic lesions in MRI in some patients after 50s, who reach 50 age
You
of
should
50.
check the myeloma.
I should check the myeloma.
Absolutely.
Absolutely.
Usually this patient goes to physiotherapy, clinic, neurosurgery, orthopedic.
This is what I'm talking. Yeah.
Usually the diagnosis comes
Misdiagnosis, so they spend a lot of times out.
the disease progress.
Disease progress.
Yeah. And then kidney problems comes more.
I see. So you mentioned 4 courses of chemotherapy, then
stem cell
therapy, autologous.
For every myeloma patient.
For every myeloma, there is no acute myeloma.
Yeah.
It's always chronic disease.
Yeah.
Okay. So after myeloma, we have lymphoma.
For lymphoma,
I'm sorry to interrupt you, Hojam. Did we anything missed about myeloma disease? If I didn't ask you some important part, can you
for the myeloma patients, they have very severe bone pain. They usually take some drugs for the bone pain, and they wait. Do not wait. Give the treatment. Go to proceed this autologous transplantation, and that's it. And also, these patients shouldn't take the non-steroidal inflammatory drugs for the pain. It increases the kidney problem. So for painkiller, we do not recommend non-steroidal anti-inflammatory drugs for myeloma patients.
Okay, is it also the same for COX-1 inhibitor and COX-2 inhibitor, or no, you can take COX-2 inhibitor?
You can use COX-2.
COX-2 inhibitor you can use.
Yeah.
Okay, in myeloma disease.
Yeah.
Okay, let's talk now about lymphoma.
There are 3 types of lymphoma: Hodgkin lymphoma, and B-cell lymphoma, T-cell lymphoma. Non-Hodgkin lymphoma, 2, B-cell, T-cell. For Hodgkin lymphoma, at the first step, we give just chemotherapy. If the first chemotherapy, disease progress, and then or disease relapse again 1, 2, 3 years, we recommend to give treatment first, and then autologous stem cell transplantation. If the Hodgkin disease relapse after autologous transplantation, we give new treatments. There are new treatments, and then after, allogeneic stem cell transplantation can be done.
Second time.
So chemotherapy just first line, second line autologous transplantation, third line allogeneic transplantation. New drugs can be used everywhere, and CAR-T and other things. Hodgkin lymphoma for CAR-T not widespread. Developing treatment, we should wait. For the developing countries, it is very expensive. So physician should go first chemotherapy, relapse autologous stem cell transplantation. Hodgkin lymphoma, first line treatment is just immunochemotherapy or chemotherapy. If the disease relapse after the first line chemotherapy or during the treatment, if the disease progress, we have to do second line treatment and get the response, and then autologous stem cell transplantation.
It is totally different drugs in the second after relapse.
After the second autologous transplantation, if the disease relapse, and then we give the treatment, and then we proceed to allogeneic stem cell transplantation.
I mean, the drugs after relapse, it's totally different medicine.
Yeah, every step, different drugs we are using.
Every step different.
We are using. Usually, after the relapse, before the autologous transplantation, we are giving 3 course chemoimmunotherapy and then autologous transplantation. 2 or 3 course, we are ordering PET-CT. If the PET-CT is normal, we are going to autologous stem cell transplantation. If PET-CT is still disease, we have to give new treatment, and then we have to get remission, and then we have to go to the transplantation.
Hocam, you mentioned in the myeloma that the patients it is disease after 60s, like when someone reaches age 60, then it is usual myeloma disease. What about Hodgkin?
For Hodgkin is frequent in younger people between 15 and 30 years old.
Is it any sex preference, like female more, male more?
Usually both sex. And also frequent after age 60 also Hodgkin frequent. Hodgkin bimodal age young people and older people.
Older people, young people, and older people,
And
in both female and male.
Yeah, both.
Okay. Hodgkin lymphoma, is it when you talk about three types, you told me three types of lymphoma: Hodgkin, B cell, and T cell.
Sure.
Hodgkin has a better prognosis than T cell and B cell.
Hodgkin first line with the just chemoimmunotherapy, we are treating 80% of the patients.
Without transplantation.
Without transplantation, yeah.
80% of patients.
80% of the patients will cure.
Okay.
So 20% of the patients can go to autologous transplantation.
Is it frequent we use radiotherapy in patients who has Hodgkin disease?
Early stage we are using stage
Early
1 or stage 2, but with chemotherapy. First we are giving chemotherapy, and then after 2 cycle or 4 cycle we are giving radiotherapy, early stage.
Radiotherapy to where
the disease localized.
So we do PET-CT, and if there is some residue of disease in some lymph nodes, we do.
If stage 1,
okay.
we gave 2 course chemotherapy, PET-CT normal, but we give also the radiotherapy, just consolidation.
For consolidation.
Yeah. PET-CT can be normal, but we have to give the radiotherapy.
In
for
Hodgkin
the
disease, what is the chance to get relapse without bone marrow transplant?
20% of the patients relapse. Again, we do autologous transplantation. 50% of the patients relapse after autologous transplantation.
Okay.
So 50-50.
Okay.
And after the autologous allogeneic, 40% of the patients cure, and then 60-70% of it can relapse.
Is there any control in Hodgkin disease, like in myeloma, in Hodgkin disease, after bone marrow transplant done, everything is okay? Yeah, is it like in other cancer types, like solid cancers, we do 3 months control in PET-CT, MRI, something similar
myeloma,
in the blood disease?
For myeloma, every 3 or 6 months,
PET-CT?
just
MRI.
control the blood test,
Okay.
if need, MRI or PET-CT. For Hodgkin disease, usually we follow 5 or 7, 8 years. If there is no disease, we stop.
Okay, so follow-up in Hodgkin disease is 5 to 7 years.
Usually every 6 months, or if necessary 3 months.
Okay.
5 years we follow. If there is no disease, we can say cure. But sometimes it can relapse after 6 or 7 years, rarely.
Is it follow-up PET-CT or blood test?
It is usually first 2 years, every 6 months PET-CT.
Okay.
After 2 years, every year PET-CT. After 5 years, if you needed the PET-CT.
Okay. So
2 years every 6 months.
Okay.
And after 2 years, between 2 and 5 years, every year.
One PET-CT.
After as needed.
Okay. So in myeloma disease follow-up is blood test.
Yeah.
In lymphomas, Hodgkin follow-up is PET-CT.
Yeah.
Correct.
Yeah. Hodgkin cure, and then you don't need to follow up.
Okay. So we talk about
But myeloma you have to follow up.
Follow-up with blood test.
Blood test all the time.
All the time.
Yeah.
Every 3 months.
Every 6 months or 3 months.
Okay.
Usually 6 months.
Okay. So we talk about myeloma, we talk about Hodgkin disease. Now for T cell and B cell lymphomas. As we mentioned, T cell and B cell lymphomas, non-Hodgkin lymphomas, are worse prognosis than Hodgkin.
Correct.
Worse prognosis. So can you explain how often it is? What is the age?
Usually non-Hodgkin lymphoma occurs 14-15 patients every year, 100,000 people. So non-Hodgkin more frequent than Hodgkin 4 times. at least 5 times more frequent. And non-Hodgkin lymphoma, B-cell lymphoma more frequent, and T-cell lymphoma less frequent. Usually we see B-cell lymphoma. B-cell lymphoma, diffuse large B-cell lymphoma more frequent. After follicular lymphoma, mantle cell lymphoma, the other lymphoma. But the B-cell lymphoma has a lot of subtypes. So for the B-cell lymphoma, sometimes diagnosis can be mistaken. Hematopathologists should evaluate the lymphoma patients for the correct subtype of the lymphoma diagnosis.
Is it medicine different depending on the subtypes?
Yeah, the treatment can be different. For mantle cell lymphoma, different. For follicular lymphoma, different. For large cell lymphoma, different. Large cell lymphoma has germinal center type, non-germinal center type, and also double hit lymphoma. So this type's lymphoma treatment also can be different.
Okay. Is it B cell better prognosis than T cell?
Yes, B cell prognosis better than T cells generally.
In general, okay.
Yeah. For B cell, diffuse large B cell lymphoma, first line we are giving just treatment, and 50% or 60% of the patients cure with this treatment. We don't need to do any
bone marrow transplant. Hocam, question. In myeloma disease, in Hodgkin disease, we talk about autologous bone marrow transplant, right? So in B cell and T cell lymphomas, is it always autologous, or we can do other types of bone marrow transplantation? How does it work?
For T cell lymphoma, first step, except ALK positive T cell lymphoma, the other subtypes we do first treatment 6 course and then autologous transplantation for T cell lymphoma regularly.
Okay.
For B cell lymphoma, usually we treat with the chemotherapy if the disease relapse, except double hit lymphoma or mantle cell lymphoma or progressed disease. And for this, the autologous transplantation, after the autologous transplantation, disease relapse, then we proceed to allogeneic transplantation.
So there is allogeneic transplantation in lymphomas.
Yeah,
if disease relapses, if patient had the autologous already and it is relapse, then chemotherapy, then allogeneic bone marrow transplantation.
Also for the double hit lymphoma, if the treatment responding slowly, we do directly do allogeneic stem cell transplantation for double hit. For double hit lymphoma. So it depends the subtypes and the response to treatment.
I see. What about getting pregnant after Hodgkin lymphoma? We mentioned that the Hodgkin lymphomas is occurring in young generation, like female. Yeah. So if it's 20 years old girl, then she got disease, and she got treated. It's not active disease, okay? So she recovered from this. Can she get pregnant? And it is not contraindicated?
It is not contraindicated. After 2 years, they can marry it.
Okay.
We recommend.
Okay.
And another thing, this question is really good. Before starting the chemotherapy, the patients should cryopreserve the ovum and sperm. This is sometimes forgotten. For every patient, before starting the chemotherapy, we evaluate the cryopreserving of ovum and sperm.
I see.
So this is regular standard practice. Sometimes it is forgotten. Most of them allogeneic. Very rare autologous transplantation. Very special conditions. For allogeneic stem cell transplantation, if put the diagnosis of acute lymphoblastic leukemia or acute myeloblastic leukemia, when you are starting the treatment, you should order also the HLA typing of the donor. And then you should search for the donor also. And then after the remission induction and consolidation treatment, you should find the donor in this period. And then you have to proceed the allogeneic stem cell transplantation. if you do not look to HLA typing, do not look to donor, if you think after the two-line treatment, then the patient should, until the transplant, should receive another treatments, and then every treatment give some problems to body. So this is not good to wait. So please, for ALL patients, AML patients, put the diagnosis, look the HLA typing, cryopreserve the ovum or sperm, and then give the treatment. After 2 course treatment, go, if the transplant need the patients, proceed the stem cell transplantation. Allogeneic.
Hocam, acute leukemias has better prognosis than chronic leukemias, is it?
No. Acute leukemia patients, chronic leukemia patients survive just drugs for a long time.
Okay.
For acute leukemia patients, death rate more. Death rate more.
Faster.
Yeah, during the treatment, you can lose of the 10% of the patients.
I see.
And then after, during the transplant period, you can lose of the 5-10% of the patients. And also disease can relapse in spite of the allogeneic stem cell transplantation. Usually, roughly, 50% of the allogeneic stem cell transplantation cure and long-term survive, but the rest, 50% relapse in spite of allogeneic stem cell transplantation.
I see. So, acute leukemias, they are shifting to chronic, or it is a separate division of leukemias? It is acute and it's chronic.
Yeah.
By beginning, it is chronic, and by beginning, it's acute.
Acute leukemia usually starts with an acute. Does not change the chronic leukemia. But the chronic myeloid leukemia and chronic lymphoid leukemia continue the chronic and then turns the acute leukemia.
They can turn to acute.
The chronic leukemia can turn. Chronic myeloid leukemia can turn acute myeloblastic leukemia and also acute lymphoblastic leukemia.
I see. 2
types. Chronic lymphocytic leukemia can turn to Richter syndrome, which is also dangerous like acute leukemia. So chronic leukemia can turn to aggressive disease, but acute leukemia
it's always
does
aggressive.
not turn to chronic leukemia.
Okay. So acute more aggressive than chronic leukemias.
Correct.
Okay. So we have 3 types of oncology hematology: myeloma disease, lymphomas, and leukemias. Now we have another diseases which is not covered in oncology. It is not oncology, but it's still BMT required.
Okay.
Aplastic anemias.
Aplastic anemia and also myelodysplastic syndrome.
Myelodysplastic syndrome.
This is like a subtype of leukemia. For myelodysplastic syndrome, we do allogeneic stem cell transplantation. Usually it is less done for the patients. Usually the physicians forget to send the transplant. For myelodysplastic syndrome, can be cured with the allogeneic stem cell transplantation. So the physician shouldn't be late to send the patients the allogeneic stem cell transplantation. For aplastic anemia, allogeneic stem cell transplantation is very useful procedure. If you do not give more blood transfusion, the transplant excess increase. Allogeneic transplantation success more than 90% of the patient, no more than 90. So you are giving some drugs for aplastic anemia, and also you are giving the blood transfusion. You are decreasing the allogeneic stem cell transplantation chance and the morbidity increasing if you wait more.
So in other words, if someone has aplastic anemia
less than 40 years old,
if the
aplastic anemia is severe or very severe, should continue the allogeneic stem cell transplantation as soon as possible.
As soon as possible. Very important.
Yeah, very important.
Very important.
Don't give the drugs. Don't visit the drugs. Look the donor as soon as possible. Go to transplant.
I see.
For the other not very severe, moderate, or the patients older than 40, then you can give anti-thymocyte globulin, cyclosporin, dexamethasone combination treatment. It is useful for the 50% of the patients, but it is cost like allogeneic stem cell transplantation. Usually, if the patients comes to me, young patients, I recommend to directly go to allogenic, because allogenic stem cell transplantation first step success rate more than 90%.
I see. Hocam, how many patients with aplastic anemia? It's also occur in older age, what you mentioned before 40.
Yeah.
So
most of them less than 40, but also older age. We have some aplastic patients.
What is the cause of aplastic anemia?
What is the
Cause.
cost?
Cause.
Cause. We don't know exactly the cause of aplastic anemia, but hepatitis B, hepatitis C. Usually, if we diagnose the aplastic anemia, we have to check hepatitis B, hepatitis C. If the aplastic anemia related with hepatitis B or hepatitis C, you should go to allogeneic stem cell transplantation. Usually, hepatitis B, hepatitis C, secondary aplastic anemia does not respond to outcome or other treatment. Please go to proceed allogeneic stem cell transplant in this group patients. Also, if the donor is antibody to hepatitis B, and then you can treat the hepatitis B also, you can cure the hepatitis B also after allogeneic stem cell.
I see. Is there any medicine cause aplastic anemia?
Medicine, there are chemotherapy also caused aplastic anemia, and also a lot of drugs can cause aplastic anemia. For example, rarely paracetamol also can cause aplastic anemia. We are asking the patients first which drugs they are using. Also, some plants drugs. This is common in the people. They are using to get more healthy. Some vitamins, some things. They are also can cause the aplastic anemia type problems.
I see.
So I have a patient with using papaya. How do you say papaya? Yeah, and
this is plant.
Yeah, plant. And then it caused aplastic anemia and liver problem. He did allogeneic stem cell transplantation.
I see. As a doctor, Hojam, is there anything people can do to avoid leukemias, lymphomas? Oh, it is
my first recommendation: control the stress.
Control the stress. Okay.
And avoid to use some recommended plants, drugs like this.
Okay.
Just eat in the market what sold.
Okay.
Don't do different things, and the most important thing, control the stress.
Okay, so you don't recommend some medicine which is made from plants. Usually don't take, and just eat healthy, avoid stress, do physical
exercise.
Physical exercise.
Yeah.
Okay.
Do not smoke.
Do not smoke. Okay.
Do not smoke.
Is this smoking also can cause
alcohol
social? Okay. Hocam, back to Anadolu Hospital. You started working in Anadolu from 2010.
Correct.
Up to now.
Yeah.
So you did a lot, 3,500 bone marrow transplantation in total, more than 3,500.
Yeah, more than 3,500. Correct.
In some years in Anadolu you did 300. Now we around 100. So last 2 years it is usually about 100 bone marrow transplantation per year. I see. How many people working in the bone marrow transplant team in Anadolu?
In Anadolu, in our team, I think 35.
35 people.
3 physicians.
3 doctors.
Nurses more. Nurses very important.
Nurse is very important.
If you do not teach the nurses, your nurse team is weak, you couldn't do good things.
I see.
So our nurses work as a physician.
They are like physicians.
Yeah, like physician.
I see.
I don't need much physician. I need the
Nurses.
nurses. I need
Okay.
the nurses. And also the other personnel is important. They have to know contamination, infection risk, everything.
Okay. What is the most important in bone marrow transplant? Like it is after bone marrow transplant. So it is sterile box before and after.
Usually for autologous transplantation, the patients stay 3 weeks in the hospital.
Okay.
After 1 or 2 weeks, we outpatient, and then we send to home.
Okay.
So it is more easier. The transplantation, autologous transplantation is not problem.
It's not a problem.
The death rate is less than 1%. So it is not dangerous treatment. It is just treatment, not real transplantation.
Okay.
For
Okay.
allogenic transplantation, yeah, it is real transplantation. The patients stay 1 month usually in the hospital, and then we follow the patients 2 months outpatient every 1 or 2 weeks regularly. And during this time, we teach the patients and the family. Family support for allogenic stem cell transplant is really important. If there is no family transplant, the support, we do not do allogenic stem cell transplantation. This is key point.
Okay.
So family support, they do at least 6 months, 1 year, these supports contain. The patients usually return the working after 1 year.
After 1 year.
After 1 year. So
After
1
allogenic.
After allogenic.
After autologous, like after 1
autologous,
month,
after
2
6
months.
months. 6 months.
6 months.
6 months. If needed, after 3 months.
Okay.
3 months.
A physical exercise is not contraindicated after 6 months. 1 month.
After we discharge from the hospital, we recommend every day.
What about food?
Food, there are some green vegetables can give some problems.
Okay.
Because of these vegetables, during first 3 months, we avoid. And
Okay,
then
so it is processed food, should be processed food.
It's processed. And if you need 2 times wash, wait, and then they can eat.
Mhm.
So for the vegetables, they should be careful. The
Okay.
other things is after discharge, free
Okay, vegetables or fruits also?
vegetables.
Only vegetables.
Only vegetables.
Fruits not it's also all okay.
Which foods, for example?
Grapes,
Grapes, huh? No, grapes.
apples,
For apples, soyarsanız sorun. If you kabuğunu soymaya ne diyorsunuz? Kabuğunu soyarsanız apple yiyebilir.
Okay.
Armut da yiyebilir. Hepsini yiyebilir.
Tamam. Anarda okay.
Okay.
Okay. So Almanı şey
Ama herkes, we are educating every patient, we are giving the list of food.
Okay. So there is a list of what you should
Yeah,
avoid,
yeah,
what you can eat
Regularly.
regularly.
We are following 1 week.
Okay.
At the control, we are looking. If the patient's disease some problems, we are supporting new things. We are saying new things. If patient's condition good, then we are giving bonus, new foods.
Mashallah, understand. Hocam, when I was learning medicine, preparing for some exam, I don't remember. Somewhere I read that when patient has in box before BMT or after BMT, even the flowers cannot be bring inside.
Yeah,
Is it true?
Flowers, we do not accept any flowers to inpatient clinic in the rooms.
Okay,
It is forbidden.
forbidden.
Forbidden.
Flowers not. It's,
And
can be dangerous for patient.
dangerous for the patients. And fungal infections can get from the vegetables. Pneumonia, everything.
Everything. I see.
Sinusitis, everything. So it is forbidden.
Okay.
And room is important for the allogenic stem cell transplantation room. And room should be sterilized. And corridors also should be sterilized. And in the USA, they accept some hours visiting the people. But in our center, we do not accept because Turkish people does not control yourself. So
Emotional.
yeah, emotional.
Emotional. I
Yeah,
see. I see. Hocam, how many beds available for BMT in Anadolu?
22 bed.
22 bed.
Yeah.
I see. There is no ICU after bone marrow transplantation.
We have general ICU.
Okay.
Our general ICU is a sterilized ICU. It's a every room different.
Okay.
The patients, all the patients, every room, separate rooms. Usually ICU, 4 patients, 6 patients, the same room. But in Anadolu, rooms is different.
Okay.
So every patient's every one room and
Okay.
sterilized room.
Single room. Single.
room.
Okay.
Yeah. So we used our Anadolu ICU.
I see. So how often ICU is required for patients with after transplantation?
Usually, one patient in 10% like this or 5.
Okay. Is it
5
because some complication?
Yeah, complication, infection, usually
Infection.
infection.
Because of infections, they usually require ICU. If
Yeah.
there is no infection, it is just staying in the box,
Yeah, and then we are treating.
and after 3 weeks, 4 weeks,
Usually
discharge.
we are discharged.
Discharge. I see. Thank you so much,
Okay,
Hocam.
you're welcome. I hope
it was very interesting to talk with
it
you.
will be helpful for the patients.
Thanks
Thank you.
for a lot to treating patients from Uzbekistan. So many patients actually love you and admire you.
I love
You know?
the patients also.
So many
Thank
patients
you.
are very grateful, and I am very grateful
Thank you.
to having you here today.
Thank you.
Thank you.
Thank you.